Welcome everyone to our ADSSP webinar. Let's go ahead and begin. The Alzheimer's Disease Supportive Services Program grantee webinar today is facilitated by the ADSSP National Resource Center, which consists of RTI International and the Alzheimer's Association National Office. Hello, I'm Sari Schumann with the Alzheimer's Association National Office in Chicago, and I will be moderating our webinar this afternoon. Our ADSSP National Resource Center team also includes Liz Gould, Josh Weiner, Jan Mayer, Kate Gordon, Patty Ewan, and Katie Maslow as an advisor to the project. As a reminder, the purpose of these ADSSP webinars is to provide helpful, current, and applicable information for ADSSP grant projects and others in the Aging Network. Please note the webinar today is being recorded. At this time, I'd like to introduce our speaker, Dr. Laurel Coleman. Dr. Coleman is a member of the Alzheimer's Advisory Council at the Department for Health and Human Services and participated in the Council's work developing a national plan for Alzheimer's disease and other dementias. She is a geriatrician and a palliative care specialist. Currently, she works at the Maine Medical Center's Geriatric Assessment Clinic and at Central Maine Medical Center, where she is an attending physician on the palliative care team. We will allow time for questions through the webinar's chat feature at the conclusion of the presentation. You are welcome to enter questions as they come up while Dr. Coleman is presenting. At this time, I will turn it over to Dr. Coleman.
Great. Thank you very much. I'm really pleased to be here virtually, I guess, on your computers. We'll just get started. I want to leave plenty of time for questions. I was asked to speak about palliative care for people with dementia, and I'm just going to start out with a couple of definitional slides here, or just to sort of set the conversation so we all are talking about the same thing. So palliative care is sort of more in the news in the last couple of years, and you probably are aware, but it is specialized care for people with serious illnesses. Its focus is on symptoms and quality of life, so often the focus of traditional medicine, which is more on generally cure, this is something different. This is for people with diseases or multiple chronic illnesses that aren't better, don't get better, maybe treatable, but not entirely curable. And it really has a quite different focus being on the patient and their preferences for care given their experience, and then the focusing on quality of life. It's commonly misunderstood to be just the same as hospice care, but it's not, because this is the kind of care can be given at any phase of the disease. It can be provided simultaneously with curative treatments. It doesn't have to be an either-or choice. It involves a multidisciplinary team like good geriatrics care does as well. And we do try to maintain all the previous medical relationships that people have and incorporate them and include them in this type of care. Some people misunderstand that this is just about, they think it's just about pain management, but it's certainly more than that. There are many more symptoms such as agitation, weight loss, depression, apathy, and many more, especially that pertain to dementia that we'll be talking about. There's a strong focus on advanced care planning and patient preferences. So very briefly, although I suspect that every person on this call could give a definition, an accurate definition of dementia, I'll make just a couple of points. Dementia is a group represented by a group of symptoms, not just memory loss, although that's usually present. And these things affect someone's thinking and social abilities severely enough to impair their ability to function independently. We know that Alzheimer's disease is a major cause of dementia, but there's lots of contributors that work together to ultimately affect how a person functions and what their cognitive abilities are, and I've listed the most common here. This is a more recent change. 10, 15 years ago, we would spend a lot of time diagnostically trying to sort out what kind of dementia is this. And while we still do that, we realize that people often have multiple contributors. The person with vascular disease, risk factors, may likely have some of that, but they're also very likely to have Alzheimer's disease pathology as well. Another condition that's growing and being more common is sleep apnea. Well, untreated sleep apnea might cause hypoxia, low oxygen in the brain, which could lead to vascular damage or hypoxic damage, and that could affect the onset and experience of dementia. All of you know this is very common illness. Over 5 million Americans currently have some form of dementia, but surprisingly and frustratingly, less than half those people usually have it documented in their medical records. There's at least 2 million people with advanced or severe dementia. Some of the research we'll touch on today focuses on the most severe stage of dementia, and that's people who are non-ambulatory, nonverbal, dependent in all of their activities of daily living, and that's probably a slightly smaller number of about 1 million people. Most of those people live in long-term care or certainly with full support at home. And then clearly lots of people are involved in the care of persons with dementia and the decision-making as well, and that probably is nearly 14, 15 million people. So why are we focusing on dementia and palliative care rather than other illnesses? We could focus on other illnesses as well, but this is a really unique syndrome, dementia is. And one of the reasons it's very unique is that other illnesses generally don't cause someone to lose insight into their disease process. Sometimes that happens very early in the disease process, and sometimes it comes later with advancing dementia. But for many illnesses where we talk about palliative care or a palliative approach, the patient themselves is making all the decisions about what they'd want as the disease progresses or the syndrome progresses. But in the case of dementia, many people at the time of diagnosis or fairly early in the disease have impaired insight or decision-making capacity, and depending on when they're diagnosed. And that makes this very different. This means greater caregiver burden, as caregivers are not only needed to care for someone, but also to make decisions. And as many of you know, the very difficult situation of someone not believing that they have a problem, not needing help, wanting to manage their finances when it's clear that's not going well or is risky for them. It also means there's less ability to ask the person what their preferences for care are over time. It may mean that we have a shorter window of possibility to have the discussions about what a patient would want as their disease progresses. And I think that is a very challenging situation. Just in Washington, D.C. earlier in the week, as we're having a year-long expert panel on advanced dementia to inform the National Plan for Alzheimer's Disease at the federal government, the question was, should advanced care planning, advanced directives happen very early in the course of this disease, almost on the first visit? And there was a lot of dialogue about that. Ideally, the answer would be yes, but the common sense tells you that there's so much to educate a patient and family on around at the time of diagnosis that getting all the way to their preferences for care means understanding the disease progression, accepting it, being able to ask questions about it, and then proceeding to that. And it means it's very difficult to get to that in what's usually incredibly limited time for healthcare providers. So it's unique in many ways, I think. Dementia is a terminal illness that used to not be discussed very much at all, but it is being discussed more as the fifth or sixth leading cause of death. I think it's very underrepresented on death certificates, but this is a terminal illness. Lay audiences almost always ask, well, how do you die of dementia? And certainly there's all the usual suspects as someone ages, that they can die from a heart attack, something sudden, a stroke, or an infection, or those related to other diseases that they have, like heart failure, COPD or emphysema, where they might have inputs that are of slower onset. Coming from just the dementia, we see commonly weight loss and eating problems, feeding problems, often malnutrition. Recurrent infections are common for a variety of reasons, sometimes organ failure, and death can come because of these other medical illnesses or treatments for other diseases as well. There's been a lot of attention lately around persons with advanced disease having hypoglycemia, low blood sugar, from over-treatment of their diabetes, and that tight control, which may be appropriate in earlier ages or in a more robust population, is often not adjusted as people get older and more frail, so that hypoglycemia is a very serious risk and should be thought of. Dementia prognosis is very difficult, and there's been multiple studies looking at what might be good flags or markers for a terminal decline, but this is incredibly difficult and has been elusive. So a 6-month prognosis, which is what the hospice benefit asks for if someone's in their terminal decline, we don't do much better than 50-50 when using some of the markers that have been identified. This is very difficult clinically, but it also makes policy and health policy around something like hospice or palliative care very challenging as well. One, I think, serious barrier to good palliative care, to good process of involving the patient and family, is that as healthcare providers, unfortunately, we, on average, rarely discuss advanced care planning with patients and families. It's certainly different than it was a generation ago, with more of those conversations happening, but I think in dementia that is still not common. More rarely even than just the general advanced care planning, people, healthcare providers don't necessarily talk about the major issues that will happen over the course of the disease process, like challenges with feeding, infections, and other common things to expect. Providers routinely overestimate prognosis, even in advanced dementia, and there are multiple studies to look at this that have shown this. And that limits, when you realize that that's common for whatever reasons, and we could spend a lot of time going into that, but for whatever reasons, when we overestimate prognosis, that robs people of making good plans, making accurate plans for what a person might want or what they themselves might want. A reminder that when we refer to severe dementia in most studies, that this is very severe. This is, and I put the definition there, someone who has very minimal language abilities, is incontinent, struggles to walk independently, can't recognize families, and needs help with everything, including eating and feeding. So another aspect related to healthcare providers is that we physicians, nurse practitioners, PAs, are not reimbursed to speak with caregivers when the patient isn't present. So for many patients, while you may focus on the patient in the room and speak to them and provide them as much information as is appropriate, there are lots of questions about safety, about what caregivers can do better, what their resources are for caregivers, to talk about advanced care planning, And it's more appropriate in many situations to do that separate with the patient not there. And yet there's very little or no reimbursement for this. And you'll see as we go along that this can have real implications. We know from lots of studies of caregivers that they long for this, that they wish they could have time asking questions with the doctor away from the patient, as they don't, they need honest answers, but they also don't want to make the patient feel bad or scared or more confused. So why palliative care rather than usual care? How about just usual medical care? Why should it be different, and why should we use this approach? I've talked about this being a severe illness where patients need a lot of focus on advanced care planning and symptom management. We'll talk more about that aspect soon. But the reason why palliative care specifically is a good match is that it really does, at its core bedrock, palliative care focuses on patient and family preferences and quality of life. We spend a tremendous amount of money on usual care for people with dementia. And that's okay as long as if it was quality care, if it would match with what they want. But research shows that we usually get poor outcomes as measured by traditional measures, people improving, leaving the hospital, getting cured of what they go to the hospital for, but also poor outcomes as measured by families. Families and caregivers generally think that persons with dementia don't get good care in traditional settings like hospitals. So a few little facts: persons with dementia in community settings have higher rates of hospitalizations and ER visits. There are lots of transitions of care for persons with dementia, especially more advanced dementia, into the advanced and severe stages. A recent study showed that cardiac pacemakers are placed in persons with dementia at almost twice the rate of people without dementia. Now that's shocking news. You have a terminal illness, much akin to someone having metastatic cancer, a terminal illness, and yet a device, a medical device, that's not going to change the underlying disease is placed at almost twice the rate of a similar age person without dementia. They don't exactly know why that is. Some of it may have to do with families feeling like they want, quote, everything done for a person, or are unclear about what the person's wishes might be in this scenario, or they're not well educated by providers about what actually a pacemaker means. Research also shows that survival after hip fracture and pneumonia is very poor, is about half the survival rates of a similarly aged person, matched for other diseases, but just one without dementia. So traditional care doesn't result in traditional outcomes. Symptom management is also generally poor, and multiple studies have shown that for the same injury or illness, such as a hip fracture in one study, persons with dementia get less pain medicine, and less pain medicine by quite a bit. There should be no reason they don't have the same feelings and the same symptoms, but for whatever combination of reasons, their comfort is often neglected in terms of using pain medicines. Often it's the fear of delirium, which is a real concern, but can certainly be managed, and palliative care helps with that. So how might you think about advanced care planning in early stage disease? In a perfect world, if you had that time set aside, what kinds of things would you focus on as far as advanced care planning for early disease? So you'd certainly discuss disease progressions and common scenarios, things a person might face, and you do that with the patient if they were willing to participate in that and engage that. But if not, then the caregiver. We would bring up support system. What are the plans? What's plan B if you can't be a caregiver anymore? How are you taking care of yourself? We talk about safety issues. And then we talk about goals of care. What are your goals of care? And for many people, it is to live as long as possible. But for others who might be facing dementia or other illnesses or a combination of other illnesses, they may have different goals of care. You want to think about how to discuss that with the particular patient. What's important to you? What's your definition of quality of life? Some people are incredibly articulate about that definition. They're very specific. Others haven't really thought about it and are more general about it. So you can use different scenarios to illustrate possible choices someone might have. If you're not able to have X, what they would like as far as the end of their life, how then would you want us to intervene? So we talk about scenarios of accident, stroke, things like that, where there's possible significant disability or need for long-term care services, and see what a person or a surrogate decision maker might say in those scenarios. And then we often would mention that palliative care moves with the person throughout their care, even into end-of-life care. A common question people in palliative care ask is, when it is the time at the very end of your life, where would you like to be? If we could get a strong answer in that regard, we often can really help a patient and a family navigate the healthcare system to be able to honor that preference, what that is. It's often a home setting or a family setting, but not always, and it's really important to ask. Early on in a disease process, it's very reasonable to speak about the choices of medications. What are your goals for medicines? Let's look at your particular medicine. The reality of treating some medical conditions is that you're trying to prolong life into the most severe forms or levels of dementia, and that's not people's goal sometimes. A very interesting article that you might have seen in the news recently just came out September 8th, just 3 days ago, related, it was in JAMA, Internal Medicine, Journal of the American Medical Association, and talked about prescribing practices for that physicians engage in nursing home patients with advanced dementia. And interestingly, very high percentage of people with advanced dementia, very severe, were on medicines that were not indicated for them, and probably had side effects and a significant downside, like cholesterol medicines, using some of the Alzheimer's focused medications in very advanced disease. So not only cost side effects, but also physical medical side effects as well. Very interesting article, and I'd refer you to that along with the editorial by Greg Sachs in the same issue. Another thing is to really focus or to really bring up that people need a plan for hospitalizations, and not just for the patient, the person with dementia, but often the caregiver is a spouse or a friend, and what are we going to do if you need to be hospitalized? So always having a plan B there. As the dementia progresses and we move into more advanced stages, we continue to have ongoing discussions about goals of care. They will change over time. We keep asking in a nice way. And then as things come up, we begin to ask questions of how to treat the other diseases. As you know, many older people, most, have more than one condition. And treatments often cause burden and discomfort for patients. What medication should we offer? What about screening tests, mammography, colonoscopy, and other kinds of tests? Maybe something that someone's done routinely, and they just assume that they need to continue it. But their experience of that testing or that procedure is entirely different as their dementia progresses, and their risk for side effects and worse outcomes occurs too. We explicitly talk about caregiver burden, or we should, and it's very underappreciated. as well as really the financial implications of that burden. There's not always easy solutions to that, of course, but I do find that it's very important to acknowledge the trade-offs of this long-term caregiving, and helpful to the family or caregiver that they hear that we understand what they're going through. I talk in that last section there about, quote, the promise. Many, many people will have asked or asked their loved one, please don't put me in a nursing home, anything but that. Make me the promise you'll never do that. And we really need to discuss that honestly with the caregiver and the patient if possible, but the caregiver especially, because the person who asks that is not thinking about what the implications are for the caregiver, how long the disease lasts, how much total care not only costs financially but costs physically on caregivers. And I hope we continue to develop more and different models for caring for people with advanced dementia. But right now we have a system that doesn't really help much with this long-term chronic illness financially. So let's just say a few more things about hospitalizations in advanced dementia. I call this the square peg in a round hole, because everything in the hospital is not designed for a person with dementia, as many of you realize. All the processes, from the call bell to tell me when you need to get up to go to the bathroom, please do this, to leaving a tray of food nearby the bed and expecting somebody to process that, organize it, and eat it. None of it works for someone with dementia. Falls and delirium are much increased. You've dislocated the person. They have an illness. You're giving them new medicines. They don't have their hearing aid often, their glasses. They're disoriented, and things get bad fast. Family involvement is and their constant presence is a really important factor, and a good caregiver is there a lot trying to help the patient, and it isn't a break for them. And interestingly, as people advance near the end of their life, they use the hospital system a lot more than those of a similar age without dementia, but interestingly with much worse outcomes. And there's some reasons for that. We're going to keep going on that subject. When Sean Morrison looked at 6-month mortality after hip fracture or pneumonia, this is several years ago now, and matched them for age, and they didn't tell the doctors what to do as far as treating the person, so this is all comers, and they had all levels of therapy and repairs of hip fractures and antibiotics. But people with dementia, about half of them died within 6 months of the hospitalization, and that wasn't true for this age-matched other group without dementia. And that tells you that this is a magnifier. This is an illness that changes the game and changes the rules for even common illnesses. Often the hospital doesn't fix the problem. I mean, there's a few examples. If you have a bad laceration or you break your wrist, you're hoping to be fixed. But for many of the common scenarios like recurrent pneumonias and aspiration, repeated hospitalizations and ICU care doesn't fix the underlying problem. And we need to work with families and caregivers to understand the realities of what's happening to the person's body as their dementia is advancing. Even when families understand, though, I think it's important to realize that we don't have a system that helps them in other ways. And for them, especially if they're caring for a loved one in the community, or maybe not even a loved one, whatever kind of caregiver they are, all paths seem to lead to the hospital. And that's true often in the nursing home setting, or the home setting. Where else is someone going to turn for that person that's short of breath, with a fever, maybe a pneumonia, if it's not the emergency room? Even the long-term care setting is not well designed to do that evaluation and treatment there. I think that's going to change some and is changing some, but we shouldn't beat up on caregivers just because they use the ER frequently. They don't have many other options that are timely and useful to them. And then longer stays and readmissions are certainly more common too. Briefly about pain medicine and pain management, it is really challenging when we usually rely on someone to tell us how are you feeling, rate your pain, did this help you, and with impaired memory, they're not likely to remember how they felt. So you have to use dynamic assessment strategies. Right now, how are you feeling? And continue to do that and use other facial expressions or other methods for pain assessment in people with advanced dementia. We may use trials of medication. Could this be pain that is causing this restlessness or this crying or agitation? We don't want to use as much PRN medication or as-needed medication because that requires a person to realize what's happening and then complain about it. And therefore, it's not likely to happen, and they're not likely to get medicine. I wouldn't say I never use it, but it's very judicious, and I usually use more scheduled pain medicine rather than allowing it to be just on an as-needed basis. Studies have shown that persons with dementia get less pain medicine, as I've mentioned before, and it can certainly be an important source of agitation and challenging behaviors. And you'll hear story after story about the person with difficult behaviors that's transferred from nursing home to nursing home, placed on antipsychotics, that really flourish with taking a lot of those other medicines away and using low-dose pain medicine, that at some level there's discomfort as the basis of some of these challenging behavioral problems. And now that's considered one of the first things we should try in a person with agitation and challenging behaviors. Weight loss and eating problems are also common. This is the nature of the disease process. Difficulty swallowing comes for almost everyone as they move into advanced stages. There are good strategies in terms of feeding from our occupational and speech and swallowing therapy colleagues that can help a person maintain that function for longer and to do it safely. But there is, I don't think, as much uptake on that or as much availability of those approaches as there should be, and we need to keep working on that. Weight loss certainly can occur with even people who eat well with dementia. Often people who are restless or pace, they're expending a lot of calories as well. It is clear in study after study, and it is pretty much an issue at rest now without controversy, that feeding tubes in advanced dementia are not the answer, because there's no consistent evidence that there's longer survival or less aspiration pneumonia or improved skin healing or any improved quality of life for a patient that has a feeding tube. And yet we still do see these happen, and that was a big subject this week in our discussion as well at the expert panel this week in Washington, that it's often costing long-term care facilities more money to have staff that spends time hand-feeding people, and in a way they're getting more reimbursement for using feeding tubes because they can hang a bag of food, liquid food, and not have to spend the time with the patient. So that's what we call a perverse incentive. It's not something that's good for the patient, and yet it in some ways is being incentivized. Medicare is looking at some of that. And then also a recent study showed that feeding tubes were more commonly placed in larger hospitals, in hospitals that were for profit, and by doctors, attending physicians who were subspecialists than people who were hospitalists or primary care physicians when they led the care team. Fever and infections are also common. We don't often know why that is. Sometimes it relates to aspiration, but other people say there is an alteration of the immune system that makes people more susceptible to infections. It is very remarkable the amount of antibiotics given in response to fever, especially in nursing home patients, and it certainly leads to antibiotic-resistant organisms that we see the big problem of in long-term care in hospitals. So there was a study by Susan Mitchell, it's in your references, looking at antibiotic usage over 18 months in 21 facilities in the Boston area. And then in a person with advanced dementia, and this is the very advanced dementia patients that I mentioned earlier, the average was 4 courses of antibiotic per patient in that 18 months. And half the patients died in 18 months, and almost half of them received antibiotics in the 2 weeks prior to death. So people are really receiving and dying with antibiotics on in many, many cases. There is some good evidence that for most infections that we can use simple oral antibiotics rather than IM or IV, if that's the patient and family's preference or the family preference. And we can do this as an outpatient, not in the hospital. But again, our systems aren't well designed to facilitate this. Imagine if you're the caregiver at home of someone with advanced dementia, they have a fever, they're short of breath, you call the doctor's office, you're waiting for a call back, they seem to be uncomfortable, and what are you going to do? You're going to use the emergency room because you're concerned that they're suffering, and you don't have someone to call unless you're on hospice to come over and do a home visit and help you with that. There's a lot of system barriers to good palliative, comfort-focused care in dementia. Being hospitalized raises the likelihood that you're going to be placed in skilled care after your hospitalization. A study in 2006 showed 40% of patients who died in long-term care with advanced dementia had used their skilled nursing facility benefit in the last 90 days of life. So what does that mean? Okay, you think, what's the difference, skilled care, nursing home care? Well, skilled care is designed for rehab, for getting better. And people with advanced dementia rarely get better, sometimes in a limited way from an acute illness. But for the most part, that doesn't happen very often. And when you use your skilled benefit, then you can't use your hospice benefit at the same time. But the burden on the families to decide, use the skilled benefit, the government pays, the Medicare benefit pays, or go into long-term care or get home care and hospice and pay for the nursing home bed or pay for the extra care you need at home. That's a tough call for most families and an expensive one. When hospice care is engaged and used in advanced dementia, there is a very significant difference in whether you die at home or hospital. You're much less likely to be in the most expensive and sort of depersonalized place of dying, the hospital, if you have the hospice benefit. So that's been shown over and over. When we talk about palliative care, it's not a structured system. People understand hospice better, but palliative care isn't as structured. In some places it's hard to access, although many, many hospitals offer palliative care, and many cancer centers, and sometimes even in the outpatient setting, although that's more rare. So we need a greater understanding and maybe even some enhanced reimbursement and structure for palliative care. So as we sort of wind down here and move to questions, palliative care makes sense because this is a terminal disease process, and we want to emphasize discussing goals of care and quality of life as a major priority in our work with persons with dementia. Our usual medical care is often a poor fit for a person with dementia, but as I've tried to explain, there really are few other options than usual care. I'd love to see, when hospitalization is necessary, a dementia-focused hospital ward, for example, that looks a little different, that has a higher staffing ratio, that moves people around and helps them get out of the hospital faster. But that's very uncommon. There's a few sort of pilot programs, but very uncommon. There's very little incentive for providers to spend a lot of time with families to discuss these important issues. Of course, using area agencies on aging and the Alzheimer's Association, those are common referrals. But when you get to questions around medical care and what to choose and what to expect, families and patients expect that to come from physicians and other healthcare providers, other primary care providers. And the system doesn't allow for much time to be spent, and we think that's a very significant missed opportunity that ends up hurting the patient, the family, and costing our healthcare system more in the long run. And that our system should be redesigned to promote palliative care throughout the disease process, getting more satisfaction, enhancing caregiver support, developing more options for care outside of hospitals and nursing homes, because that's not what people want in these most expensive and really depersonalized sites of care. So I think I've done okay on time, and I'll listen or read for questions. Read and listen for questions.
Thank you so much for that presentation. Very insightful. We can open for questions now. You can enter your questions in the chat pod, and we'll pause for just a few moments while a queue of questions is assembled. And then I will read out your questions so Dr. Coleman can answer them.
Sorry, I can answer that question about the title and journal. Would you like me to answer that?
Yes, great.
Okay, so earlier on I spoke about a recent article in JAMA Internal Medicine, recently published in the online version just this week, and the title is Use of Medications of Questionable Benefit in Advanced Dementia, and it's in the September 8th online edition of JAMA Internal Medicine 2014. That means it will come into a printed form later, but it's online now. And then there's an accompanying editorial by Greg Sachs about that article in that same journal. So you can search that.
Okay. The next question is, what is the criteria for receiving palliative care? At what stage of dementia? You know, this is cutting off. Hold on one second. I'm going to switch to a different layout. There we go. At what stage of dementia would people be eligible for a referral?
Well, the answer to that is really any level. Palliative care doesn't at any stage of dementia because, and I tried to make that point, you know, there's different things we would do and focus on at different stages of the illness, but different stages of dementia, but really any stage is appropriate. This is a terminal illness with the definition of it is, by the way, that you lose insight and judgment and decision-making capacity, so you can make a strong argument that you want to start this focus early in the process. However, I told you, finding someone to do a palliative care consult, especially in an outpatient setting, is very difficult. It mostly occurs in hospitals now, and it doesn't mean you have to have a palliative care person attend to this. You can ask about advanced care planning from primary care physicians, et cetera. But if you have access to palliative care in your community, it is appropriate at any stage, I would say.
Great, thank you. There's another question that came in that says, can you offer any comment on palliative care for people with intellectual disabilities affected by dementia, such as people with Down syndrome?
Yeah. So this is a very interesting question, and I'll just give a little bit of background for people who maybe aren't as familiar with this. So it turns out that the genetic mutation that causes Down syndrome also causes heightened accumulation of amyloid protein in the brain, which contributes to the development of Alzheimer's disease. So a very high percentage of persons with Down syndrome, as they age, develop Alzheimer's disease. That wasn't known a generation or so ago, or two, because people often died of other illnesses before getting into this risk factor age, which is generally in the 40s and 50s and 60s, although it is younger than a typical person with Alzheimer's disease. So I would say that, again, the concept of palliative care, this is a serious illness. It deserves a strong focus on the person, what their preferences are and what their goals of care are, and symptom management, again, is very appropriate for the group of people that you're asking about, persons with intellectual disability and Alzheimer's. However, I would say that we would try to maintain the structure of their support network and care early on in the Alzheimer's disease syndrome, and that could look very different for a person with Down syndrome that may be more likely living in a group home or going out to day program, etc. But as people advance, they become much more similar in the very advanced stage with persons that have Alzheimer's without Down syndrome. So I think then we're looking at seeing a more similar situation where long-term care is used more, where people are hospitalized, where their caregiver or home or group home situation is less able to care for them as they're sicker. So then they might come into contact with more kind of traditional care pathways and options for palliative care. But short answer, should be absolutely considered in the same way I'm encouraging you to consider palliative care for all stages of traditional or typical Alzheimer's disease.
Great, thank you. We have a few more questions coming in. One person did ask about accessing the presentation, and we will send that along with the references at the conclusion of the webinar to those that have participated today. The recording of the webinar will be available shortly on the AOA website on the grants page, the Alzheimer's disease grants page in particular. So I hope that answers that question. The next question is, if diagnosis of the 6-month hospice limit is so difficult, how can individuals use dying with dignity laws to make sure his or her wishes are followed?
Well, that is a very interesting question, and I guess the real answer is I don't know. I think that to step back from the dying aspect of it, but just someone's care preferences, in which case we don't have any sort of 6 months estimate. We're not just talking about the dying with dignity laws. But I think this points to trying to elicit people's preferences and goals of care early in the disease process, and then doing our best to help navigate their care over time to try to achieve those goals. So, I could give you different scenarios, different examples, but, an easy one would be that somebody says to me, most important thing is I want to be in my own home. I never like doctors. I've never liked hospitals. I don't want to die in a hospital. So that, for me, becomes an organizing principle. How are we going to make sure to follow their strong wish. And so that's how we then make decisions about other aspects of someone's care, from where they live to what medicines we're using, et cetera. And that would just be an example. So I'm not tied to the 6-month part. We don't really begin to have that discussion at the 6-month line. We start much, much earlier. This dying with this focus on the last 6 months and the prognosis aspect is very difficult, because you realize that someone is incredibly impaired when their dementia is so severe to have hit that 6-month hospice eligibility part. So they are not participating in decision making at that point. So I think the challenge would be somebody that early in the disease said, when I get to this point, X, then I want, X and Y. And I think I have had patients like that, and when, as long as it doesn't involve me hastening their death, as long as it doesn't involve me, doing anything that causes them to decline, I don't have any problem following their wishes, that they have said no medicines, nothing that tries to prolong my life, if and when I get to this stage. But that would be a much longer discussion. I hope that helps, though.
Thanks. You just answered part of the next question, which is, do you have thoughts on when palliative care ends for a person with dementia and hospice care begins? You just were talking about that a little bit, and how people can plan for that. Do you have anything else you want to add before I move to the next question?
Yeah, well, all I'd say is palliative care doesn't end, even on hospice, right? It doesn't end. Palliative care continues. The focus, the type of care continues. It's just that hospice is really, you're asking about the defined benefit, the defined hospice benefit by Medicare.
Right.
And they're very specific about what triggers an ability to use that benefit right at the end of life. And so I think the biggest challenge with the Medicare hospice benefit is that often when they become involved, when a hospice becomes involved with the person, that augmented care, that extra time feeding, that extra interaction often stimulates the person to do a little better for a time. And then Medicare says, well, now they're not dying. You have to take them off the benefit. And that creates an on-again, off-again a challenge. So it is not a great model. The traditional hospice Medicare benefit was designed for cancer patients. And now we're seeing people with heart failure and dementia and lung disease, and they don't fit that model well. So we're in the process, I think, as a country, of rethinking how that benefit works. But palliative care continues throughout the disease process and up to the time of death, even if someone's on hospice.
Great, thank you. The next question is asking if you think the federal government should consider a type of hybrid, team-oriented palliative care, hospice care option for Alzheimer's disease and dementia patients that might be able to last longer than 6 months.
The short answer is absolutely yes, and many people are advocating for that. If you think of what a U looks like, a U-shaped curve, hospice expenditures are very high early when you refer someone to hospice, and then as long as they're not actively dying at that time, the costs go down as the intensity of service isn't as great in the first, after the first couple of weeks. And then near the time of death, the expenditures go back up on the other side of the U. So why not pay hospice teams for the intensity of care over time rather than a fixed daily benefit that's the same at all times? Why not allow it to be more flexible and not be so geared to the timing, but just the level of the disease process, the needs of the family and the patient, and we are advocating, many people are advocating for that. our third meeting of the Advanced Dementia Expert Group is going to talk about policy issues that help care for people with advanced dementia and policy aspects of our healthcare policy that are barriers or actively hurt people and families with advanced dementia, so that we can make some of these specific recommendations to the Secretary of Health and Human Services, hopefully to be included in this next year's Alzheimer's plan.
Okay, great. We actually have one more question, which will take us to the end of our time. The question is, in the absence of a better system that provides palliative care in an outpatient setting, what are the steps dementia families can take with their primary care providers to move somewhat toward palliative care with them?
Yeah, I would say that if the primary care provider is not talking about some of the things that I mentioned in the presentation, if they're not bringing up advanced care planning, if they're not bringing up caregiver stress issues, if they're not bringing up and caregiver support options, if they're not bringing up questions like, as this worsens over time, what would you like to have happened, and really engaging that, then the families can prompt those discussions, and or the patient can. Again, this is a tough disease. There are certainly people with Alzheimer's disease early on that have insight into what they're experiencing, know the disease process. And those people advocate for themselves often early in the disease to get the legal and financial things done and to get their wishes made clear. But the majority of people aren't in that space at the time of diagnosis, so we rely on families and caregivers and friends to come alongside and help make those things clear. So if you're not seeing that, then ask for it. Ask, is there a person that does palliative care? Ask if there's a geriatric specialist or somebody that specializes in Alzheimer's disease. Call the association and ask about advanced care planning. Some states have physician orders for life-sustaining treatment forms. Those are more specific advanced directive forms for people with serious illness, and really act as orders, medical orders about, certainly CPR, but also tube feeding and artificial hydration and nutrition that are much more specific for people with advanced illness. And I think that those can be good later in the disease process. So ask, advocate, and even demand that some of these things get discussed. And if palliative care is around and available, ask for them.
Thank you so much for all your responses to the questions and also for your great presentation, Dr. Coleman. We thank all of you for attending today. That's going to wrap up things for us on this webinar, and we will be in touch about our next scheduled webinar in the coming months. Thank you so much, everyone. Have a great afternoon.
Bye-bye.